they didn't have any histories with them, but you know they're at least there. You're in the sellar region, so your differential diagnosis probably were a little bit more narrower than it would be otherwise. So first, I want to start with a little bit of introduction on normal pituitary. So normal pituitary, this is what the two components that you learn about in medical school or reading on your own is that the normal pituitary has the adenohypophysis, which is part of the endocrine organ or the endocrine component of the gland, and the neurohypophysis, which is an extension essentially from the hypothalamus. It also secretes hormones, but it doesn't have the hormone producing cells are in the hypothalamus. And the cells that you see that are nucleated here are essentially specialized glial cells known as pituitary, which we're going to discuss briefly. Something that allows you to recognize as such is the herring bodies, which are dilations of the distal axons, where some of the hormones, for example, oxytocin, are released. So this is something to have in mind to get used to. But it doesn't have normal. There are some stains that are helpful for us to identify normal components of the pituitary. A reticulum in particular highlights this very nice tight lobular architecture of the pituitary, which is very helpful. This architecture is very helpful in many ways, particularly when you have the H&E is not showing things very well, the cell distribution, because this type of small little lobules like this in the very delicate capillary network is really typical of the adenohypophysis, and the reticulum is a special thing that plays a role, particularly in small crush biopsies. Neurofilament protein also is helpful to recognize the neurohypophysis because, as I mentioned, this is composed predominantly of axons that are going down. So other items in the differential diagnosis of the neurohypophysis, which sometimes can be cellular, for example, Schwann cell tumors or spindle cell tumors, will not have these intricate, elaborate aggregates of axons in them. So those are two stains that can be very helpful in just identifying normal. And if you think about a little bit more, particularly if you had to do, for example, frozen sections of pituitary lesions, you have two possibilities. Most of the time, you have only two possibilities, which is, do you have just normal pituitary, so it hasn't been sampled, it hasn't been taken out by the surgeon, so you can guide the surgeon to take the actual lesion, or you have an adenoma. Those are the two main items that you have, and sometimes these stains with time can be helpful to you on permanence. In the time of the frozen section, smears are very helpful, and just seeing how the cell smear will tell you a lot. You have the adenohypophysis. Actually, it doesn't smear very well. That's a clue that you probably are dealing with something normal or something fibrotic. But if you have let's assume that you have a biopsy for the first time, this is what normal adenohypophysis looks like, and this is how an adenoma smears. So this, just looking at the glass slide, will tell you a lot. Normal pituitary should never smear this good, so this will tell you that you're dealing probably with an adenoma or rare lesions occasionally. This is on high power. When you start going on high power, you start seeing these little aggregates and very little single cells in between. And then the adenoma, which is basically a sheet of the cells of the real that are of the same cell type. Remember that the adenohypophysis has multiple cell types that you can identify by the cytoplasmic quality. You can have crush artifacts. These are some permanent sections. These can be worrisome. Sometimes they get these. We see this in consult with a question: is this some sort of small cell carcinoma or lymphoma that we're missing or something? Sometimes just doing a Ki-67 will highlight this as having a very low Ki-67 will be helpful to recognize. And this can happen with normal pituitary or with adenomas. So it's nothing to be very concerned about. It's just that the normal pituitary and the adenomas tend to are very susceptible to crush artifact. As far as different cell types, you have different distributions of the cell types. So you may have, even in normal pituitary, a little bit of excess of GH cells, or if you are in the lateral side, it's probably the growth hormone cell, somatotrophs, or the cells that are responsible for growth hormone are the most abundant ones, particularly in the lateral lobes. ACTH and TSH tend to be in the middle, and then you have the gonadotrophes kind of scattered around the gland. And this you'll see that you have, as we're going to discuss, some adenomas that recapitulate this type of cell of putative cell of origin in neoplasms. All right, so with that introduction, let's now go into the cases. We have the first case, which was a 29-year-old male, presented for several years with low testosterone, had some symptoms, and then was evaluated, and they found that, and had a prolactin level of 29,000, which is very high. So the upper level of normal in some ways for adenomas is maybe 125. But this is a 29,000, so this is almost diagnostic of a prolactinoma from the clinical side. The patient was started with cabergoline, which is a dopamine agonist, and the prolactin that went down to 400, but never completely normalized. So the patient went to surgery. Most of these prolactinomas now are being treated with surgery, with medical treatments first, and but when they still are symptomatic or continue to grow, they have to go to surgery. And this was label 1A in your virtual slides. It's not the most attractive smear, but it's very illustrative, and there's a reason why I place it. So these, if you see the smear, is cellular. It's spreading. It spreads well. It's not the best. So you are here in doubt a little bit. Well, are you sure it's not just a normal pituitary? You go on higher power, and you can start seeing that probably the cells are not spreading very well, but they are still the same cell type, probably. Round. Spreading a bit better than a normal pituitary. And this is the corresponding frozen section control. This is a permanent slide. So this one could be tricky if you don't. The history is very helpful there. And what you're seeing now is you start say, well, there are the lobules. You're not seeing that lobular expansion that you're going to see in many more typical adenomas, as I'm going to show you briefly. But you start seeing a lot of fibrosis and small shrunken cells in many areas. Okay. This is something also, if there's the crush, if you have crush artifact here, you can again start getting worried about a metastatic carcinoma or lymphoma, or in this case, even sometimes you can start being worried about lymphoma. You see the cells have very little cytoplasm, and this is what happened when many of these tumors that get resected after treatment with some of the dopamine agonists, the cells shrink, and you can get some fibrosis, calcifications that can be a little worrisome. But this is still an adenoma. Here, your reticulum is not going to be as helpful because you see you have a lot of dense fibrosis. Here, probably in some areas, you start seeing more typical adenoma. So this is something that, and you see you may have apoptosis and other effects of this treatment. So, but definitely you do have an adenoma. Now we want to prove that the adenoma is expressing your hormone of interest, and this is prolactin. So you see the prolactin is very strong in those intact cells all around. So this is actually a prolactinoma. Or now the WHO, on the WHO and some of the literature, the proper term to use is lactotroph adenoma. This is the imaging, and the imaging of the sellar region can be tricky sometimes. You're seeing here a sagittal and here a coronal, And what you're seeing actually is an adenoma that is actually large, is enlarging the cella. It's actually, there was at least described that this was greater than 1 centimeter, which is the cutoff for macroadenoma. Any adenoma is greater than 1 centimeter is considered a macroadenoma. And it was also described as invading the cavernous sinus. So it was behaving a little bit more aggressively, and which also was one of the reasons that was resected. So this is lactotroph adenoma or prolactinoma. I still use that term, but this is what you encounter in the WHO classification. And this is the recent WHO classification of endocrine tumors. They have a very nice section on pituitary adenomas. And these are the ones that are recognized. You have the somatotroph, or the ones that produce growth hormone associated often with acromegaly, lactotroph, which are the prolactinomas, thyrotroph, corticotroph, gonadotroph, null cell, and plurihormonal. And within them, you have a few subtypes. Now, which are the ones that are associated with more aggressive behavior? That's always something that comes up. And these are the ones that are recognized, particularly that are important to recognize because they may be associated with more aggressive behavior. You may be aware that atypical adenoma as a category that was used in the past is not used very much anymore because there's a lot of other features, particularly adenoma subtype, extent of invasion, and other clinical features that are more indicative of the aggressive behavior than just having a little bit of an increased proliferation, although it's good to mention the proliferation in the report. So as you see, this tumor that I just presented is actually one of the subtypes that are associated with more aggressive behavior commonly. So it's the lactotrophs macroadenomas in men. This is a specific category. Then you have some of the somatotrophs, this particular variant, which is the sparsely granulated, Crook cell adenoma, which is frequently associated with Cushing. So it's a specific corticotroph subtype. The silent corticotroph adenomas, that means the ones that are not associated with Cushing. And this one that is tricky to identify, which is the plurihormonal PIT1 positive adenoma, since you probably need the PIT1 antibody to recognize it, and not all labs offer it. But those are the ones that are important to have in mind regarding potential for more aggressive behavior. Okay, let's move to the next one, which is case number 2. This was a 66-year-old woman, had a head imaging after a fall, and they found an incidental pituitary lesion. Now, going back in the history, they saw that the patient actually complained that was gaining weight for the past 10 years, predominantly in the abdomen, and also had some hirsutism. They checked then, they had a hormonal endocrine evaluation, and they noticed that the patient had an elevated urinary cortisol, and a non-suppressed ACTH, which confirmed the diagnosis of Cushing's disease, and had a gross total resection of the lesion. And here's the MRI again, sagittal, a T1 post-contrast, and then a coronal. If you see here, this is the lesion. This is your sphenoid sinus here, your clivus. Something, if you notice, something that's very typical, if you see in the brain, most of the lesions that you encounter, they are described as enhancing. That's something that allows you to recognize many of the pathologies that you see in the brain. In the pituitary, actually, the pituitary is the one, the normal pituitary is the one that enhances usually. As I show you, it has a very dense capillary network. So many of the adenomas are described as non-enhancing. That's what allows you to recognize them. Many of these adenomas that are associated with Cushing's can be very tiny, actually, and even silent, even difficult to find, even by imaging. So, but subtleties like these, areas of non-enhancement within the pituitary are very suggestive in many instances of a pituitary adenoma. And this is the lesion. Again, you're seeing, you're in the pituitary, you have an endocrine problem, so it makes it a little bit easier. That's something that's very useful in evaluating this lesion. If you have a very nice endocrine evaluation prior to receiving the specimen, and you see you have a single cell type, large cells, You can argue there's a slightly granular, slightly basophilic cytoplasm. Rare pleomorphic cell. Let's move around to see what else we find. So and you have also a loss of the normal architecture, right? A single cell type, loss of the normal pituitary architecture. So it looks pretty much the same all around. And of course, immunohistochemistry helps you here as well. This is ACTH. So this is a very nice positive ACTH result. So you confirm the clinical impression, and this is a cortical trough adenoma. That's the diagnosis, and this one is functioning. So remember that they can be functioning or silent. The functioning are the ones that have these effects. They have Cushing's, and the silent are the ones that continue to grow many times, and they present usually as macroadenomas and are considered to be more aggressive biologically. All right, let's move to case number 3, which is a 71-year-old male. It was having a workup for sweating episodes, and they found hypopituitarism in endocrinologic evaluation, and also had bitemporal defects in neuro-ophthalmologic examination, meaning probably that you had a large lesion that was probably compressing the optic chiasm. That's another symptom of sellar tumors. You have a compression of the chiasm from below. This patient also had a gross total resection. This is the imaging, and you can see here is your lesion. It's a large lesion. Actually, you can see it's going up, extending up into and probably compressing the chiasm there. So large sellar tumor. And this is what you have. It's a tumor that you can describe probably as amphiphilic, slightly eosinophilic cells. Some of them are clearer. You get a feeling that still you have a single cell type, more or less. You have trabecula. And something else that we need to have in mind with pituitary adenomas, they can have a lot of architectural variation. This one you see has more of a trabecular arrangement, smaller nest, but still larger than normal pituitary. A little bit variation in cell quality. Something that you're seeing also, if you may have an impression that probably you have a couple different cell types here. Actually, you have these cells here, and you see the cytoplasm is slightly more granular, slightly more pink than these smaller cells here. And that is oncocytic change. And oncocytic change, you can see it sometimes in some of the adenomas. It's actually something that I see with frequency on this particular subtype. As you notice, the patient didn't have any good endocrinologic symptom. Here you also have a suggestion of perivascular pseudorosettes, which you can see sometimes in some of the adenomas, not to be mistaken for a ependymoma. And we did some stains, and this is SF1. And SF1 is a very useful stain. It's a transcription factor, as you see. You see it as a nuclear stain, and it's one of the markers of these gonadotrophic adenomas. It's not one of the adenomas that you need to recognize all the time. It's not necessarily associated with, doesn't have that much clinical significance, but you have a very nice marker here that is helpful even more than the hormones, really, to identify. So it's something that if you have this antibody in your lab, allows you to specifically identify these subtypes. Things that make you think of it: older patients, then that are relatively silent, or these produce FSH and LH, but you have, with particularly in women, you can have a lot of elevations of these. So they are difficult to identify from the endocrinology standpoint, but they are slow growing and not necessarily associated with aggressive behavior. In this particular case, we also did FSH. And you see the FSH and these and the LH tend to be weak and focal many times. They can be altogether negative and still be considered a gonadotroph. These are very tricky hormones to get to work. And you see they can be very focal and very easy to miss. So that's why the SF1 has become a little bit of a better marker for these particular adenoma subtype. This is the FSH. This is the LH. Again, you have some focal areas with positivity, but you see it's subtle, and sometimes it's even subtler than this. So something to have in mind. Adenoma in older patients with a bit of a trabecular arrangement is frequent. Pseudopapilla are frequent in this particular subtype, and oncocytic change. And again, the SF1 immunostain really allows you to confirm the diagnosis of this subtype. So this is a gonadotroph adenoma. Let's move into case number 4. This is a 67-year-old male, bumped his head and had imaging for periodic hearing loss. And you see this is a frequent, it's not uncommon to have incidental now MRI masses identified doing MRI for something completely different, for trauma or for something else. But this patient happened to have a pituitary mass. It was followed by imaging, but it grew over time. So it went to surgery. And this is a tumor. And actually, this is a tumor, a case that I received in consult just recently. It was very puzzling because here, from the morphologic standpoint, there's a wide differential diagnosis, actually. Well, there was some concern. Could this be a metastasis, right? I mean, you can have a variety of metastatic carcinomas, even a sarcoma. Had these several pleomorphic cells scattered around. Let's see here. So you have here, from the morphologic standpoint, you have a broad differential diagnosis. But again, when you're in the sellar region, the main thing that you have to think about is whether this could be any of those limited primary tumors that you can get in the region, particularly an adenoma subtype or something from the neurohypophysis. So it's something worthwhile staining. Now, something that can be of help here is doing a synaptophysin first. And this is the synaptophysin in this case. Strongly positive, right? When you have the combination in the sellar region, or even in the head and neck anteriorly of strong uniform synaptophysin staining, low proliferation, no mites. This one, the Ki67, was also very low labeling index. that is very suggestive of pituitary adenoma of some kind. So that's something that those are two stains that will be very helpful in narrowing your differential diagnosis. Even if you don't have a good hormone, even if you don't have good endocrine clues. So strong synaptophysing, almost all adenomas strongly and uniformly express synaptophysin and other neuroendocrine markers. Synaptophysin is the most sensitive, probably, but that's they do express it. To be even a little bit more specific, I added INSM1 from my end, and you can see it's a cleaner stain. You've been probably seeing some literature of these on INSM1 and for a variety of neuroendocrine tumors, particularly tumors of the lung, but in other areas. But it's also frequently expressed by adenomas in pituitary, in the normal pituitary. So you see here those pleomorphic cells as a nuclear stain are staining very strongly for INSM1. So neuroendocrine neoplasm, low proliferation. I was suspecting this was some sort of adenoma subtype, even though the morphology was very unusual. And something that helped here was TSH. Which was strongly positive. The other hormones were relatively negative. So TSH adenoma is one of the rarest adenoma subtypes. The reason I'm showing it is because it is many times can engender broad differential diagnosis. They can be very pleomorphic. They can be spindly. So they can have very unusual morphologies that can be very puzzling. So in this case, we thought about that, particularly based on the neuroendocrine marker expression, and the TSH really showed it. My understanding there was no endocrinologic, it was a very vague history, but that there was no real necessarily any indication of thyrotropin excess. Some of them can be silent, but most of the time, if you really look at it very carefully, you can find some endocrine abnormalities in the blood. So this is a TSH adenoma. Thyrotropin adenoma. Okay, the next one is case 5, another straightforward history, 31-year-old man with a pituitary mass. That's what we had at the time of that we received the specimen as a consult. And this is what you have. This is something that when you we look at it, well, is, are we sure we are in the sellar region, in the pituitary? What we're seeing is we're seeing a lot of ganglion cells, right? And this one is you have some that are multinucleated. When you have multinucleation in ganglion cells, you know that that's something that is probably more associated with a neoplasm. So you want to make sure when you see lesions like this that you're not in the hypothalamus for sure, because you can have a lot of nuclei that cluster, and but here you start seeing multinucleation. That certainly tells you that these ganglion cells are neoplastic. So what is this ganglion cell lesion doing in the pituitary? And look more, very bland, more of these ganglion cells. A little bit of inflammation. More of these ganglion cells, so unquestionable neuronal. Now, we move around. Start seeing areas like this. you can see the cells here get smaller, and they are more compatible with some sort of, at least have to look into the possibility of some sort of adenoma subtype here. Something that was a subtle clue on this was that you have some of these cells had a little bit of an eosinophilic eccentric inclusion. The adenoma subtype here is not immediately apparent, right? There's the cells. There's some cells that are a little bit lightly eosinophilic, other ones are not a little bit more amphiphilic. But you do have a few of these inclusions. And something that was very helpful here was cytokeratin. And this is a cytokeratin CAM 5.2. And we are seeing a lot of these little round structures. And this is a cytokeratin CAM 5.2. You also have a little bit of non-specific staining in other cells, but this is very helpful here. I'm not showing, I don't have it here, but the cells also were positive for growth hormone. And in retrospect, I believe the patient did have some evidence of acromegaly. So this is actually what recognizes, if we only focus on the adenoma, this is what recognizes the sparsely granulated somatotrophic adenoma. So basically it's sparsely granulated because you have the GH can be very weak. You have very few granules, but these fibrous bodies are very highly characteristic of it. And as I mentioned to you, if you remember early in the presentation, it's one of the adenoma subtypes that are associated with a more, potentially with a more aggressive behavior. So we're having another thing. So how do we explain the ganglion cells? Well, it's a gangliocytic component. And this is actually recognized in the WHO, and there are some publications out there describing this phenomenon of a mixed gangliocytoma adenoma. And this is a very useful reference that you can come across about this phenomenon of mixed gangliocytoma pituitary adenoma by Dr. Lopez and Dr. Sloan, in which they looked at 10 cases of this phenomenon, and actually all of them were somatotrophic adenomas. Almost all of them are somatotrophic, and almost all of them are actually sparsely granulated. So it's a phenomenon that, for whatever reason, associated with these sparsely granulated somatotrophic adenomas. Occasionally, you can have ganglion cell metaplasia and other subtypes, but this is one that is particularly a particularly strong association. They also did very nice double labeling for markers, PIT1, which again is a marker of that lineage, GH, as well as PIT1 and NUN. And they found that, of course, in the adenoma cells, all of them have these PIT1 and growth hormone expression. Some of the ganglion cells did have also PIT1. So this actually provides further evidence that actually the ganglion cell component is probably some sort of transdifferentiation from the adenoma itself. So a very fascinating phenomenon, rare occurrence, but really overrepresented with this particular adenoma subtype. Okay, moving on to the next case. Case 6 is a 32-year-old woman, had a 3-week history of headaches after delivery of her third child, and had a imaging done, and they found this 2.4 centimeter pituitary mass. And this is what you have: a low power, a very blue specimen, right? Difficult to tell even that you are in the pituitary at all. Fairly blue. And you can see on high power, cells are small and they don't have much phoretypia. A lot of these are lymphocytes. Again, the differential diagnosis, of course, is a treated lactotroph, right? With, as I showed earlier, but that's not the history here. The patient didn't have hyperprolactinemia, didn't have treatment for anything similar. You also have a little bit of fibrosis. This is here you can see in between a mixture of also some plasma cells. Just looking around, giving you a flavor of the lesion. A bit subtle, but you still have some residual acini here. And these are pituitary acini. It's not reflecting very well in the camera, but you have a variety of cell types, some of them somatotrophs and others. So you are in adenohypophysis here with a very dense inflammatory component. When we see these, of course, one of the main things that you want to exclude is the possibility of IgG4 disease, given the excess of plasma cells. We do have a rare positive cells here. IgG4 related disease can involve the pituitary. So it's something always important to have in mind when you have as far as specific disorders that you can identify. This one didn't have much. I mean, it has a few here and there, but nothing to get too excited about. Lymphomas, of course, and among these, this is a mixed, a double labeling for kappa and lambda. And you can see you have a mixture. Lambda, I believe, goes in red, kappa in brown. So you have a mixture, essentially a polytypic pattern of staining for kappa and lambda in the same slide. So at least you can argue that there's no evidence of, polytypic plasma cells at this point. And of course, the history is very typical. So this is lymphocytic hypophysitis. As you can see, I like to say many times when I see the specimens consistent with, because we do see a lot of small biopsies of the cellular region with some inflammation, and that really I really argue against not calling these hypophysitis. I mean, you have, unless you put everything together. This is a very nice actually specimen. So you have a nice chunk. You have adenohypophysis with a lot of overrun by inflammation. You're excluding infections. You're excluding other disorders. And then you're left with a clinical impression of hypophysitis. So lymphocytic hypophysitis has a presumed autoimmune etiology. Remember, the adenohypophysis is an endocrine organ, and as is associated with autoimmune endocrine disorders and other organs like the thyroid, adrenal gland, etc. It commonly affects women in late pregnancy or postpartum period, that's what we're having here. The differential diagnosis, again, for me is wide, and that's why I like to say consistent with many times. Involuted adenoma, as I mentioned, lymphoma, those are probably the two big ones. Infections, sarcoidosis if you have granulomas, and particularly germinoma. This is true in young patients in which you have small biopsies. So actually, that may even be more common than lymphocytic hypophysitis in a young patient. So, and we have seen this phenomenon in which you have a very tiny biopsy. It's called lymphocytic hypophysitis. The lesion continues to grow. They go for a second biopsy, and they find a very nice germinoma. You're obscured by this inflammation, which can be lymphocytic, can be granulomatous, etc. So that's why when you have very tiny biopsies, it's better to just describe it, try to rule out what you can rule out, and not call it directly hypophysitis. Leave that more for the clinical interpretation, or suggest an alternative diagnosis. In this case, everything fits So I felt a little bit more comfortable placing it in the consistent with lymphocytic hypophysitis. All right, next case, case 7. This is a 21-year-old woman presented with weight gain, blurred vision, headaches, polyuria, and polydipsia. So basically, symptoms suggestive of diabetes insipidus, had a very small biopsy. And you can see this is the lesion. So it's, you have the sellar here, and actually the lesion is a little bit more posterior. It's involving probably the posterior pituitary, the stalk, and part of the hypothalamus. So these are actually can be very tiny biopsies. This is not a very nice place to take pieces of. So these end up being very tiny biopsies many times. This is what you have. So I think this is it's not a very, it's a large biopsy, but it's fairly representative, right? You have a lot of eosinophils, a few other cells in between. That's where the money is, right? Larger nucleus, slightly histiocytic appearing. Maybe some grooves in the nuclei. So this is Langerhans cell histiocytosis. And sometimes, of course, here the background is very telling. This one was also Langerhans and CD1A positive. It's a very typical presentation in a young patient. It kind of the pituitary stalk, diabetes insipidus, part of the hypothalamus is involved. So it's something when you have a small crush biopsy, something that is very important to have in mind. Frozen sections can be tricky on these because you may have very little tiny pieces and the cells can look a bit more glial even. So these, I've seen some that have a very nice glial background. Part of it is reactive, or part of it that can mislead. But it's one of the classic lesions that occur in that location and that are associated with diabetes insipidus. So very nice, important lesion to have in mind. Langerhans cell histiocytosis. Case 8 is a 47-year-old male presented with a history of low libido and low mood and had a low testosterone level, again, on evaluation. And this is what you have. Again, we're looking now at lesions of the posterior pituitary. So the pituitary, this is the sellar here. This is a lesion that probably is a little bit high up, but it's actually, you can see that probably there is an association with the stalk and the posterior pituitary. This was actually a very challenging frozen section. We had very small pieces to start with here, and to show some of the very tiny fragments. We have scattered cells like this, and this was a very nice clue actually. Large cell with eosinophilic granulous cytoplasm. And this is the lesion. You can see very bland. In the frozen section, we spent some time thinking about it, because when we saw it, on the frozen section itself, um, you can see this can be it's not that cellular. You have this pink background, and something that you can start thinking about is this something from the just brain parenchyma, and in particular a very tiny frozen section that we had. So we looked at it more and more. We had those clues in the smear, and we were able to make the diagnosis actually of granular cell tumor. And here in the permanent sections confirm that. You can see very granular, very bland, essentially no proliferation. This was also S100 and TTF1 positive. So it's one part of the spectrum of these lesions that in the sella in this particular location are probably related to pituitary and are uniformly TTF1 positive. The granularity is secondary to lysosomes. So these are frequently CD68 positive as well. It's one of the lesions, low grade. As you can see, some of them can be a little larger, like the one that we were seeing. But granular cell tumor, it used to be called granular cell tumor on the infundibulum. Probably you will see it now in the endocrine WHO of the endocrine organs as granular cell tumor of the sella. So it tends to occur in that location. What differentiates this from the ones in the soft tissues and other sites is that these ones tend to express TTF1 as a marker. The next one is case 9, 58-year-old woman with a pituitary mass. Again, this was a consult, very little in the way of history. Okay. And this is what you have. Most of it looks like this. Solid mass, somewhat cellular. And you have some blood. Some areas like this. And as I mentioned earlier, you can have a lot of architectural variation with pituitary adenomas, and that was, something that we thought of when we started seeing at it first. You can have areas that have pseudo-rosettes and adenomas. You have some pseudo-rosettes here. But the more and more you see it, you start seeing that really, indeed, the pseudo-rosettes are actually very well formed, which, of course, is something that we associate with ependymomas. Actually, here more of these cell processes around vessels. More of that, and in more very well developed pseudo-rosettes actually suggest, and in any location, you can have it in many different locations, ependymoma. So, of course, you do the stains. This was the synaptophysin. We show a very weak staining. As I mentioned to you earlier, the adenomas tend to be uniformly and strongly positive for synaptophysin in almost all cases. So you have here a little bit of trace synaptophysin that's non-specific. This is the EMA, which is showing some surface staining. So this nice surface. It's not granular, it's not cytoplasmic. This is actually very typical. You have this surface staining, linear, and probably you start seeing some dot-like positivity as well. And this is the TTF1. So this tumor expressed TTF1, EMA dot-like positivity. So this is actually a sellar ependymoma. So they do occur there, and they also, as other glial lesions that occur in that location, tend to be TTF1 positive. And they are considered now under the WHO classification as one of the tumors of the posterior pituitary, which includes pituitary, ground cell tumor of the sellar region, as I showed you in the previous example, the spindle cell oncocytoma, and now the sellar ependymoma. So this is a spectrum of tumors that you can get in that location. They all are felt to be in some ways related, either to share some phenotypic findings that are overlap with those of pituicytes. And they can take any of these morphologic forms. And again, at that location, TTF1 positive expression is fairly typical, which is also the case for the normal pituicytes in that location. Okay, this is now the final case, case 10. This was a 53-year-old woman that had symptoms suggestive of pituitary apoplexy. The patient, this is many times an emergency, had a resection of this necrotic tumor, and was felt to be probably consistent with an adenoma. But 2 weeks later, presented again with sudden visual loss and headache, had very fast tumor growth, and went for second surgery. And this is what we have. You still see a lot of blood, a lot of necrosis, similar to the what you see in apoplexy. And that's why you have an apoplexy. Usually it's related, it's a clinical syndrome in some ways, and it's related to, you have these sudden neurologic deficits, headaches, and you have basically an enlargement in the sellar region, often related to a necrotic adenoma. So it's something that is very typical. Now we start looking around, and we see something like this. And still, you see these cells that are healthily poorly differentiated, large and phophilic. And certainly you can start thinking about some sort of pituitary adenoma subtype. The first thought that you should have, actually, the cells have some prominent nucleoli, necrosis, a lot of apoptotic bodies. And essentially, you have some overridden here. These are probably adenohypophysis. Here, residual adenohypophysis, probably some corticotrophs overrun by these cells with more eccentric cytoplasm. More of the normal hypophysis here, non-neoplastic hypophysis. And here again, in contrast, you have these cells. And what helps you here is this stain. This is INI1. You can see there's the normal cell population is positive, retains expression, and is lost on these larger neoplastic cells. So loss of INI1. Another thing that oftentimes we do is BRG1, because some of the rhabdoid tumors that have a preserved INI1 can have loss of other associated proteins, and this one was preserved. So occasionally we do it in combination. But you do have definite INI1 loss here. And this is an atypical teratoid rhabdoid tumor developing in the sella. So we know now that this happens there. Most of the time when you see these ATRTs or atypical teratoid rhabdoid tumors, it's a tumor that almost always you see in children and in the CNS, and they can occur in the posterior fossa, they can occur in supratentorial compartments. But this is a typical presentation. These are ones that occur in the sella, and they tend to occur actually in adult women. This is a recent paper looking at a collection of these tumors. I think there were 6 or 7. They found that the patients had a median age of 56 years old. All of them have INI1 loss, and they tend to cluster with these groups, which is this particular ATRT subgroup that you can see in children, and which is the one that is MYC, ATRT MYC. There are other groups, so like any other CNS lesion now by tumors, they all are being now subclassified in different categories by epigenetic profiles into different molecular subgroups. These tend to cluster with this ATRT MYC subgroup. Okay, those are the cases, introduction and cases, and we have some multiple choice questions, and we're going to take a poll to see if you've been paying attention. So please go ahead and log into follow this link, and we'll start in a few seconds. We'll start with some questions if you want to join. The link is also, I believe, in the Facebook and YouTube cast. All right, so if we're getting ready, we're going to move to the next, to the first question. So this is question number 1. Which of the following adenoma subtypes may be associated with a more aggressive behavior? So the polling seems to be continuing. All right, so we'll look the results. So we have evenly split, actually. The correct answer is lactotroph macroadenoma in men. So you have the densely, it's actually the sparsely granulated somatotrophic adenomas that are associated with a more aggressive behavior. Silent corticotroph, not the functioning one. The functioning ones are associated with Cushing's usually. Gonadotrophic, of course, they tend not to be aggressive, and the TSH adenomas are not necessarily aggressive. So lactotroph adenomas, sparsely granulated somatotrophic, silent corticotroph adenomas. The other ones that I mentioned were the Crook cell adenoma and the plurihormonal PIT1 positive adenoma. So next we'll move to question number 2. Which of the following adenoma subtypes may demonstrate sellar pleomorphism? Okay, so we'll look at this. And indeed, I'm happy. Most of you chose TSH adenomas. Of course, you can have pleomorphism in any essentially endocrine tumor, really. But TSH adenomas are the ones that, in my experience, that can be the pleomorphism can be really very challenging sometimes. So it's in that was the example that I shared. Next one is question number 3. Which of the following markers is positive in granule cell tumors of the infundibulum or the sellar region, in contrast to granule cell tumors at other sites? Okay. And I see that the most chose E, TTF1, which is correct. These granule cell tumors in many different sites, they express, they positive with PAS and CD68. These are markers of lysosomes, remember? So that's what gives them the granularity. S100 is ubiquitous in these tumors and the soft tissues and the infundibulum. But TTF1 is the one that is really positive at this particular location, as other tumors of putative glial origin in this location. CD163 is a specific macrophage marker, so it's usually negative. You have CD68 is positive because it's a marker of lysosomes, but CD163 being a specific macrophage marker is usually negative. Next question, 55-year-old woman presented with a pituitary mass. Histologic sections demonstrate a cellular neoplasm with brisk mitotic activity composed of cells with eosinophilic cytoplasm. Whole body imaging is negative for extracranial disease. Which immunostain may be helpful in the diagnosis? Hopefully you're not being shy. Okay, so indeed, INI1 could be helpful in this setting. It's a rare tumor, but as I just showed, ATRT, or a typical territory rhabdoid tumor, when it occurs in adults, has a predilection for the sellar region. It's a distinctive presentation of this tumor in the adult population, usually women, kind of middle age and older. So it could be helpful because if it's lost and you have, that's really is helpful in that context. As I mentioned, usually adenomas tend not to have mitotic activity or not to have much proliferation. So when you have something that looks a little bit ugly to you, or atypically at the with cellular atypia and has mitotic activity, something to have in mind. TTF1, of course, is positive in a variety of lesions at that location, but they tend to be usually low-grade lesions. They tend to be grade 1 tumors like pituitary, granule cell tumor, spindle cell or the sellar region. These are tumors that are really have a more benign course. CAM 5.2 is positive variably in some of the adenomas. There's also positive NTRT, of course, and then the other ones have CTH and CDX2 have specific uses. Okay, and this is the final question of the day. 15-year-old male presented with diabetes insipidus. MRI demonstrated a focal lesion in the neurohypophysis. The most likely diagnosis is? Okay, and indeed, the right answer is Langerhans histiocytosis. Diabetes insipidus in a young child in the with a neurohypophyseal lesion really is it's one of the classic presentations in medicine, and it's of Langerhans histiocytosis. Of course, other tumors can be associated rarely with that, but this is a real typical presentation. It's neurohypophysis, hypothalamus, and those are where you tend to see that. Okay, so let's see. Okay. So let's. All right, so I think that finishes our session. Please hope you found it helpful. It's not all-encompassing. There are other things that happen in the cella, but of course I wanted to show some illustrative problems, selected problems that we encounter either in frozen section or in our consultation practice that I hope can help you in your practice. So feel free to contact me by email or any other way, and also I'll be following a little bit the Facebook and the Pathcast site. Any questions that may have followed. I don't know if there are any questions to discuss at this moment.
Yeah, thank you very much, Dr. Fausta, for that content-rich lecture on sellar lesions. We truly appreciate it. Right now I don't see any questions on Facebook or YouTube that have not been answered. But like you said, the conversation keeps going. So if you have any questions, please feel free to post them on there, and we can go back at a later time and answer those questions. So again, thank you very much for that lecture.
Oh, thank you very much for setting up, and happy to continue with. We're gonna have some future topics in Neuropath, so keep your eye for it.
Exactly. And, I also want to let our audience know that on the 28th of November, Dr. Andres Matoso, also from Johns Hopkins, will be presenting on a GU session, and that's titled Non-Germ Cell Tumors of the Testes. So once again, I'm Emilio Madrigal for Pathcast, and thank you for joining today's session. Thank you.
Thank you all.